Hi there, my name is Joan Harris. I'm an instructor with the Advanced Studies in Critical Care Nursing. This is a two-part presentation on mechanical ventilation, this being part 2. In this presentation, we will be covering complications of and weaning from mechanical ventilation. Mechanical ventilation is a mainstay treatment in the critical care area, and positive pressure ventilation has revolutionized respiratory support for the critically ill patient. It is important, however, to understand complications that can arise from this therapy and how to minimize the effect on the patient. The longer the patient requires mechanical ventilation, the more likely complications will arise, so the goal is to wean the patient from mechanical ventilation as soon as possible. In this presentation, we will discuss the complications as a result of mechanical ventilation relative to pulmonary, cardiovascular, neurological, and renal systems. We'll discuss how the respiratory drive and readiness for weaning is assessed in the ICU. We'll understand mechanisms behind successful weaning and review methods of weaning. When we breathe normally, inspiration is brought about by the development of negative alveolar pressure relative to the atmospheric pressure. This is the result of the contraction and flattening of the diaphragm and the pulling away of the chest wall, increasing the size of the lungs and pulling air into the lungs. This negative pressure in the thoracic cavity also pulls blood into the major thoracic vessels and into the heart. This phenomenon is termed the thoracic pump, and it increases preload and consequently cardiac output. With positive pressure ventilation, this phenomenon is lost and results in a decrease in blood return to the heart, a decrease in preload, and a decrease in cardiac output. The application of PEEP will also exacerbate this effect. The increased intrathoracic pressure can also adversely affect intracranial pressure. Increased intrathoracic pressure reduces venous drainage from the jugular vein, resulting in increased venous pressure within the brain and increased cerebral volume. Furthermore, the decreased cardiac output that results from the loss of the thoracic pump causes a decrease in the mean arterial pressure. Thinking back to neurophysiology, how might this affect cerebral perfusion pressure? Take a moment to pause the presentation and answer this question. Both these factors would decrease cerebral perfusion pressure. Looking at the equation for CPP, we see that a decrease in the MAP would lower our CPP, and an increase in ICP would also lower the CPP. Positive pressure ventilation can also adversely affect the renal system. The decreased cardiac output from loss of thoracic pump decreases blood flow to the kidneys, reducing urine output. Furthermore, the low cardiac output triggers the release of antidiuretic hormone, which leads to the conservation of sodium in water. Atrial filling is also decreased, which leads to the inhibition of atrial natriuretic peptide, which reduces natriuresis and diuresis. Dilutional hyponatremia results due to the disproportionate increase in total body water to total body sodium. Positive pressure ventilation can also have a direct effect on lung tissue. As mentioned in part 1 of this presentation on mechanical ventilation, the amount of pressure required to achieve an adequate tidal volume is related to the compliance of the lungs. If compliance is decreased, a higher pressure is required. High peak airway pressures, high levels of PEEP, and excessive regional lung volumes all increase the patient's risk of barotrauma. Barotrauma can lead to a pneumothorax, in which there is air in the pleural space, or air can be trapped in the pericardial sac, causing a pneumomediastinum, or air can be trapped in subcutaneous tissues, in which the patient would present with subcutaneous emphysema. All of these can lead to hemodynamic instability and impaired gas exchange. The significance of these complications has led to the recommendations for lung protective strategies, such as low tidal volumes and permissive hypercapnia. Attention pneumothorax is another complication related to barotrauma. This life-threatening condition occurs when air is allowed to escape into the pleural space during inspiration, but cannot escape during expiration. As this increases with each inspiration, the positive pressure rises and forces a shift of the mediastinum, trachea, and larynx to the opposite side of the collapsed lung. Ventilator-associated pneumonia, or VAP, is a lung infection following intubation and mechanical ventilation for at least 48 hours. It's caused by the body's normal defense mechanisms being bypassed and exposure to microorganisms. It occurs in approximately 25% of mechanically ventilated patients and is associated with increased length of stay, hospital costs, and mortality rates. The high incidence of VAP has led to prevention protocols. As VAP is caused by the colonization of the lungs by bacteria, strategies that reduce the patient's exposure to microbials and create conditions unfavorable to microbial invasion are used. Meticulous hand hygiene is essential. The patient's head of bed should be greater than 30 degrees to reduce the risk of aspiration and subsequent aspiration pneumonia. Stress ulcer prophylaxis, such as H2 blockers and proton pump inhibitors, are important, but their use does lower the acidity of the stomach. The highly acidic environment of the stomach kills ingested bacteria. When the pH is increased, there is a risk that the bacteria may be available to colonize the lungs through microaspirations. Most ET tubes now come with the ability to apply continuous suction above the balloon. Subglottal suction reduces the exposure of the lungs to bacteria. The longer the patient requires mechanical ventilation, the more risk of developing VAP, so early extubation is key. Assessing the patient's readiness for extubation and using weaning protocols help reduce the amount of time the patient is on the mechanical ventilation. Spontaneous awakening trials in which the sedating medications are stopped and the patient's need for them is reassessed, followed by spontaneous breathing trials in which the patient's ability to be extubated is assessed, have helped to reduce the incidence of VAP. Pulmonary edema is another complication that is seen in mechanically ventilated patients. The increase in intrathoracic pressure increases the pulmonary vascular pressure, or right-sided afterload. The right ventricle must increase ventricular pressure to overcome the pulmonary vascular resistance, which increases the hydrostatic pressure, leading to the movement of fluid out of the pulmonary vasculature. This is also influenced by the increase in permeability of the respiratory membrane, making it easier for fluid to move from the pulmonary vasculature into the pulmonary interstitium. Mechanical ventilation can also cause decreased lung compliance due to pulmonary edema and lack of surfactant. You will recall from your physiology course that surfactant plays an important role in compliance by minimizing surface tension within the alveoli and reducing the pressure necessary to accommodate air. Pulmonary fibrosis is more likely to be seen with long-term mechanical ventilation, and the etiology is typically a combination of underlying disease, the concentration of oxygen required, and the duration of positive pressure ventilation. Although essential for life, exposure to oxygen levels greater than 50% can be toxic. At these levels, the oxygen-derived radicals produced outnumber the detoxifying abilities of the antioxidants. This results in damage to the alveolar capillary membrane. This places the patient at risk for developing acute lung injury with increased capillary permeability and alveolar edema. Goals of oxygen therapy should be to use just enough oxygen to maintain a PaO2 greater than 60 millimeters of mercury and an oxygen saturation greater than 90%. If higher levels of oxygen are required, these levels may be lowered to a PaO2 of 50 millimeters of mercury and an oxygen saturation level of 85% in order to mitigate the damage from oxygen toxicity. In refractory hypoxemia, other therapies such as proning or inverse ratio ventilation may be necessary. The potential complications of positive pressure ventilation are more likely to develop the longer the patient is mechanically ventilated. Therefore, our goal is to wean the patient off mechanical ventilation as soon as possible. The ability of the patient to successfully wean is multifactorial. Criteria that can help to predict the patient's likelihood of success include: 1. The patient must not only be able to initiate their own breaths, but they need to achieve sufficient rate and depth to reach an adequate minute volume. This will require adequate ventilatory drive and respiratory muscle strength, endurance, and coordination. The patient must also be awake and alert enough to cooperate. The patient must be hemodynamically stable. Generally, the mechanical ventilation settings should not exceed 5 centimeters of water pressure of PEEP and an FiO2 of 0.4. They should be able to maintain a PaO2 of greater than 60 millimeters of mercury and an oxygen saturation level greater than 90% on these settings. The patient's respiratory rate should be less than 25, with a tidal volume of 4 to 5 mils per kilogram. Vital capacity should be greater than 10 to 15 mils per kilogram, and the peak negative inspiratory pressure, which is the ability to draw air with a breath, should be greater than negative 20 millimeters of mercury. Minute ventilation should be 5 to 10 liters per minute, and the rapid shallow breathing index, or Tobin ratio, should be less than 105. The Tobin ratio is where the respiratory rate is divided by the tidal volume. Other factors to consider include adequate nutrition. The patient should be well rested. The patient should be able to clear secretions. There should be resolution of the acute phase of the disease, absence of respiratory acidosis, a stable cardiac rhythm, and the absence of a myocardial ischemia. There are several methods for weaning a patient from mechanical ventilation, and the decision on which method to use is determined by the clinician. The trach cradle, or T-piece method, involves completely removing the ventilator support but keeping the patient intubated. If the patient has a tracheostomy, the patient is removed from the ventilator and humidified oxygen is applied via the trach cradle. If the patient has an ET tube, the support of the ventilator is removed and humidified oxygen is applied directly to the ET tube. This is done for gradually increasing intervals where the patient is able to rest on the ventilator in between sessions. Another method is using pressure support ventilation. In this method, the amount of pressure support is decreased over time as tolerated by the patient. SIMV can also be used to wean the patient. In this method, the rate is decreased over time, increasing the work of breathing as tolerated. It is important to note that long-term ventilated patients may take considerably longer to wean from the ventilator due to their underlying disease pathology and the physiologic and psychological dependence on the ventilator. For all weaning methods, close supervision and support is necessary. This includes explaining the procedure to the patient, positioning the patient in semi or high Fowler position, monitoring vital signs including oxygen saturation, and assessing arterial blood gas measurements. As previously mentioned, assessing readiness for extubation on a daily basis helps ensure that the patient spends as little time as possible on mechanical ventilation, thus reducing the potential for complications. Spontaneous breathing trial, often paired with a spontaneous awakening trial or a sedation vacation, are typically done on a daily basis. When performing an SBD, the ventilator is placed on a pressure support mode at 7 centimeters of water pressure and a PEEP of 5 centimeters of water pressure. These settings are maintained for a set time until the patient has been deemed to pass or fail the SBT. Typical criteria for terminating the SBT include respiratory rate greater than 35 breaths per minute or less than 8, rapid shallow breathing index or Tobin ratio of greater than 105, sweating and anxiety, SpO2 of less than 90% for greater than 5 minutes, signs of distress or paradoxical breathing, a heart rate greater than 140 beats per minute, systolic blood pressure less than 90 or greater than 180, new ST changes or dysrhythmias, so PACs, PVCs. Institutional policies may differ, so ensure that you're familiar with the policies in the area you work. This concludes part 2 of our presentation on mechanical ventilation. If you have any questions regarding the material covered in this presentation, please contact your instructor. Have a great day.